Hello and welcome. This is Dennis Viskers from Viskers Educational Materials. That's vemonline.net. In this short video, I will try to explain anterior pelvic tilt. Anterior pelvic tilt. Let's first look at some basic terminology. Let's look at the planes. Coronal plane that divides front and back sections. Coronal. Let's say this would be the midline of the body. Going closer to the midline, medial. Going away from the midline, lateral. Now the movements that are possible in this plane. Let's use shoulder joint for example. Abduction, arching the arm up, abduction. And adduction, going closer towards the center of the body, adduction. Next plane, sagittal. Sagittal plane divides body into right and left sections. So that's slicing the body front to back. Terminology that can be used here. Let's start with the movement. Let's use the same shoulder joint. Going up, flexion. Going backwards, extension. If we want to describe structure positioning relative to each other, we can say that, for example, the nose is anterior to the back of the head. So closer towards the front of the body, anterior, closer towards the back of the body, posterior. And the third plane, transverse plane. Transverse plane. Transverse plane is going to divide body in upper and lower sections. Movements that are possible in this plane, let's use the same shoulder joint, are going to be internal rotation or pronation, or internal rotation, and external rotation or supination. Okay, so coronal plane. That's the midline. Lateral going away from the midline towards the side. Medial going closer towards the midline. Sagittal. Anterior towards the front of the body. Posterior towards the back of the body. And transverse plane, internal rotation and external rotation. Internal rotation and external rotation. That's transverse plane. Okay, now that that's settled, anterior pelvic tilt is pelvic rotation towards the front. Let's change the view a bit. Let's imagine axis go through the hip joint. Anterior pelvic tilt. Pelvis rotating towards the front. Posterior pelvic tilt. Pelvis rotating towards the back. Now normally spinal column acts like a spring to absorb the shock. So actually we need normal physiological curvature. We need normal cervical lordosis. We need normal thoracic kyphosis. As well, we need normal lumbar lordosis, and we need normal sacral kyphosis. So that's 1, 2, 3, and 4 physiological curves. Usually there's a problem with the third one. Excessive lumbar lordotic curvature means that the pelvis is tilted towards the front, and usually it will lead to lower back pain. With increased lumbar lordotic curve, we can positively say that the multifidus muscle is going to be weak. Multifidus muscle is one of the core muscles, and with increased lumbar curve, it will definitely need strengthening. Pelvis will have a tendency to tilt towards the front, since the muscles that will act on this motion will always overpower the muscles that will act on posterior pelvic. Now, as I said, we don't need completely flat back. We need normal physiological curvatures. Flattened back will decrease our ability to absorb the shock, but excessive lumbar lordosis will usually lead to lower back pain. With excessive lumbar lordotic curvature, we can positively say that the posterior aspect of the core muscles is going to be weakened. With excessive lordotic curve, pelvis is going to be tilted towards the front. Thank you for watching this. If you found this useful, please subscribe, share, like, and be liked. Thank you.